Imagine for a moment that the number your doctor has been telling you to aim for, that blood pressure target you've been hearing about for years, might not actually be the right number for you. Imagine that for decades, millions of older adults were given goals that were either pushed too hard or left too loose, and that this gap in understanding led to real consequences. Falls, fainting episodes, kidney damage, heart attacks, and strokes that, with better information, might never have happened. That's not a hypothetical scare tactic. That's a story written in medical journals, clinical trials, and the lived experiences of patients around the world. And today, we're going to walk through all of it, what the science actually says, why the old thinking changed, and what any of this means for you or someone you love who is getting older. This isn't going to be a surface-level overview where numbers get thrown at you without context. We're going to go deep because this topic deserves that. Blood pressure in aging adults is one of the most misunderstood areas of everyday medicine, and most people, including many patients who've been managing this condition for years, are working with an incomplete picture. So let's start from the ground up. Blood pressure is simply the force your blood places on the walls of your arteries as your heart moves it through your body. There are two numbers involved. The upper number, called systolic pressure, captures the force during the moment your heart contracts and pushes blood forward. The lower number, called diastolic pressure, reflects the pressure during the rest period between heartbeats. Together, these two numbers paint a picture of how hard your cardiovascular system is working and how much strain your blood vessels are under on a moment-to-moment basis. For generations, the number that medicine held up as the gold standard was 120/80. Clean, simple, easy to remember. For younger adults in reasonably good health, that benchmark still holds its ground. But as the body ages, things shift in ways that make that simple target far more complicated to apply. As people grow older, the arteries naturally lose some of their flexibility. The vessel walls thicken. The tissue becomes less elastic, more rigid. Because of these structural changes, blood pressure tends to rise gradually with age. This isn't automatically a sign that something has gone terribly wrong. It's part of the normal biology of aging. But the important questions, how much of a rise is acceptable, how much is dangerous, and what number should a person in their late 60s or 70s actually be targeting? Those questions don't have a single clean answer. And for a long time, medicine wasn't asking them carefully enough. For much of the 20th century, the standard framework was fairly rigid. If your blood pressure climbed above 140/90, you had high blood pressure and treatment was warranted. That was the line. And for older adults specifically, many physicians were even more relaxed about it. A systolic reading of 150 or 160 in a 70-year-old was often met with a shrug. The prevailing logic was that stiffer arteries needed more pressure to do their job, to keep blood flowing adequately to the brain, the kidneys, the heart. It sounded reasonable. It had a certain biological logic to it. But as research matured, it became clear that this tolerant approach was quietly contributing to preventable deaths. Studies began accumulating evidence that older adults with systolic pressures sitting in the 140s and 150s were experiencing significantly higher rates of stroke, heart failure, heart attack, and cognitive decline compared to those whose numbers ran lower. The comfortable assumption that high pressure in an older body was just nature taking its course started to crack. The turning point arrived in 2015 with a landmark clinical study known as the Systolic Blood Pressure Intervention Trial. Over 9,000 participants took part, a substantial portion of them over the age of 75. The study divided participants into two groups. One group was treated to bring their systolic pressure below 140, which had long been the standard goal. The other group was treated far more aggressively, with a target below 120. The results were striking. The group managed to the lower target saw a 25% reduction in major cardiovascular events, heart attacks, strokes, heart failure. They also had a 27% lower risk of dying from any cause during the study period. And crucially, this benefit extended to participants who were older, not just the younger and healthier members of the group. The message seemed clear. Lower is better. Even in older adults, even in people medicine had previously assumed needed higher pressure to function well. In 2017, major cardiology organizations updated their guidelines in response to this and other supporting research. The threshold for what counts as high blood pressure was lowered. Normal was redefined as below 120/80. Readings between 120 and 129 systolic were labeled elevated. Anything between 130 and 139 systolic or 80 to 89 diastolic became stage 1 hypertension. Stage 2 began at 140 systolic or 90 diastolic. The treatment target for most adults, including many older ones, shifted to below 130/80. For those at high cardiovascular risk, the target was pushed even closer to that 120 systolic threshold the trial had identified. But here is where the story becomes more nuanced, and where a lot of conversations about blood pressure fall short. The trial that drove all these changes had important limitations that are rarely discussed when people summarize its conclusions. One of the most significant has to do with how blood pressure was actually measured during the study. Participants sat alone in a quiet room for 5 minutes before an automated device took their readings. No clinician in the room, no rushing, no anxiety-producing white coat standing nearby. This matters enormously because blood pressure is highly sensitive to context. When someone walks into a doctor's office, sits down in an unfamiliar environment, and has a healthcare professional standing nearby watching the cuff inflate, their numbers often climb, sometimes by 10 points, sometimes by 15, occasionally even more. This reaction is so common, it has a name. White coat hypertension. It's especially prevalent in older adults. So when the trial set a target of below 120, that 120 was measured under controlled, calm, ideal conditions. The same person, measured in a typical clinical setting with all its usual stimulation, might read 130 or 135 without any real change in their underlying blood pressure. If a physician uses the study's target without accounting for this difference in measurement conditions, patients can end up receiving more medication than they actually need, being pushed toward numbers that are artificially low when measured the way the trial did it, but appear normal in a standard office visit. The second limitation is about who the trial included and who it didn't. People with diabetes were excluded. People who had previously suffered a stroke were excluded. People living in care facilities and those who were frail or medically complex were also excluded. This means the results, however compelling, don't straightforwardly apply to everyone. Someone with diabetes needs their blood pressure managed through a somewhat different lens. Someone who is frail, who has already had a serious fall, or who is managing several chronic conditions at once may actually be harmed by pushing aggressively toward a lower blood pressure number. This is the part that deserves the most emphasis, and it's the part most oversimplified discussions leave out entirely. There is no single correct blood pressure number for every older adult. That's not a dodge or a hedge. It's the honest truth supported by the evidence. When blood pressure medications are used, they carry real risks. Dizziness is among the most common side effects, particularly the kind that strikes when a person stands up quickly, a condition called orthostatic hypotension. For a young, healthy person, a brief dizzy spell when rising from a chair is an inconvenience. For a person in their 70s or 80s, it can be the opening moment of a catastrophic fall. Hip fractures, head injuries, hospitalizations, loss of independence. In older adults, a serious fall is not merely a physical injury. It can be the beginning of a cascade that profoundly alters the rest of someone's life. Reducing cardiovascular risk on paper while simultaneously increasing fall risk in the real world is not good medicine. It's a trade-off that demands careful, individualized thinking. At the same time, the dangers of undertreated high blood pressure are just as real and arguably more invisible. High blood pressure earned the label silent killer because it causes no pain, no obvious symptoms, no warning flares. A person can walk around for years with chronically elevated pressure and feel entirely fine, while inside, the sustained force is quietly degrading their arteries, straining their heart muscle, eroding kidney function, damaging the delicate vessels of the eye, and weakening the blood vessels that supply the brain. Over years and decades, this accumulation of damage sets the stage for strokes, heart attacks, kidney failure, and dementia. And then one day, without warning, something gives. So the answer is never simply don't treat it. It's about treating it wisely with the right target for the right person. For most older adults who are in reasonably good health and not at high risk of falling, aiming for a systolic pressure below 130, measured properly and consistently, is a well-supported goal. But that phrase, measured properly, carries more weight than it might seem. Sitting quietly for at least 5 minutes before the reading. Arms supported and held at heart level. Appropriately sized cuff. No talking during the measurement. No recent caffeine, exercise, or stress. No full bladder. These factors genuinely affect readings, and ignoring them leads to decisions based on inaccurate data. For adults who are over 80, or who are frail, or who have a history of falls, or who experience dizziness with their current medications, a slightly more relaxed target, somewhere between 130 and 140 systolic, may actually be safer and more appropriate. The objective isn't hitting the lowest possible number. The objective is reducing the risk of the things that genuinely threaten someone's health and quality of life, which sometimes means tolerating a slightly higher number to avoid the harms of overtreatment. There's another dimension worth understanding, one that gets overlooked in most discussions of blood pressure in older adults, and that's what happens to the diastolic number as people age. Systolic pressure tends to climb with age, but diastolic pressure can actually fall. This creates a widening gap between the two numbers, which is itself a signal of increased cardiovascular risk. The complication is that when medications are used to bring systolic pressure down, diastolic pressure falls too. And if diastolic pressure drops below around 60, the consequences can be serious. The coronary arteries, the vessels that feed the heart muscle itself, receive most of their blood supply during the resting phase of the heartbeat, the diastolic phase. When diastolic pressure drops too low, blood flow to the heart can become compromised, potentially increasing the risk of a cardiac event even as the treatment is trying to prevent one. This is why blood pressure management in older adults requires genuine individualization, not formula application. Beyond medication, lifestyle changes remain among the most powerful tools available. Reducing sodium intake is one of the most impactful steps a person can take, particularly as they age, because aging kidneys become less efficient at clearing sodium from the body, making dietary salt more influential on blood pressure than it was in younger years. The goal for most people managing hypertension should be well below 2,000 milligrams of sodium per day. And the hidden sodium in processed foods, canned products, restaurant meals, and packaged breads makes that harder to achieve than it might seem without conscious effort. Regular physical movement, walking, swimming, cycling, gentle resistance training, can lower systolic pressure by amounts comparable to some medications. Maintaining a healthy weight reduces the mechanical and hormonal burden on the cardiovascular system. Managing chronic stress keeps the nervous system from sustaining the kind of prolonged activation that gradually drives blood pressure higher over time. Quality sleep matters more than many people realize. Untreated sleep apnea alone can raise blood pressure significantly, and addressing it sometimes brings readings down by 10 or more points without any change in medication. Limiting alcohol to genuinely moderate levels removes another driver of elevated pressure. Home monitoring deserves special attention. Blood pressure varies throughout the day and responds to dozens of variables: food, activity, stress, position, time of day. A single reading taken in a clinical setting is a narrow slice of a much larger picture. Monitoring at home, using a validated automatic upper arm cuff, at consistent times each day, ideally before morning medications and again in the evening, builds a far more accurate and complete understanding of what blood pressure is actually doing. Bringing that record to medical appointments gives physicians genuinely useful data to work with rather than a single snapshot taken under artificial conditions. What all of this comes down to is that managing blood pressure as the body ages is not a simple matter of picking a number and medicating toward it. It is a careful, ongoing balancing act, protecting against the slow, silent damage of chronically elevated pressure while guarding against the real and immediate dangers of overtreatment. The right target is the one that fits the whole person, Their age, their strength, their history, their other conditions, their medications, their daily life. That conversation belongs between each person and their own physician, informed by the kind of nuanced understanding that goes beyond a single number printed on a guideline. Use this understanding not as a prescription, but as a foundation for better questions, better conversations, and better decisions about your own health or the health of someone you love.